Hello everyone.
My name is Lian Taoma from Peking University. I'm glad to introduce our work on clinical health representation learning. This research is carried out by Peking University Third Hospital, and Lancaster University. The oral presentation consists of four parts: the clinical background, our insights, solution, and experiment results. Above all, why do we need to evaluate the health status of patients? Actually, health prediction, for example, the mortality risk prediction, the disease prediction, is of great interest to physicians. We take the health prediction of end-stage renal disease patient as a motivating example. Currently, many people are suffering from ESRD in the world. They face severe life threats and need lifelong treatments with periodic visits to the hospitals for multifarious tests, for example, the blood routine examination. Normally, some biomarkers, such as blood albumin and blood glucose, are recorded through the treatment trajectories. The whole procedure needs a dynamic patient health risk prediction to help patients recover smoothly. Specifically, physicians can select personalized follow-up treatments, prevent adverse outcomes, assign medical resources effectively, and reduce the medical cost. The precise risk prediction requires a high level of clinical expertise and experience. Nowadays, electronic healthcare information systems are widely used in various healthcare institutions, which can record lab test results and health information of patients in terms of electronic medical records, the EMR data. EMR can be seen as a type of multivariate time series data and provide essential healthcare information for the data-driven healthcare prediction. Because of the remarkable representation learning ability of deep neural networks, many deep learning-based models have been developed to tackle such prediction tasks by using EMR data. Usually, those models first embed EMR data into low-dimensional feature space based on RN modules to learn the dense representation of the patient health, and then perform specific clinical analysis tasks. However, there are still several issues that are not yet fully resolved by existing works. First, we believe that not only the value of lab test results makes sense, but also its variation pattern contains essential information of health. For example, for end-stage renal disease patient, the long-term descending trend of blood albumin is a strong indicator of malnutrition. Also, the long-term and short-term variation trend of biomarkers show the health status of patient from different aspects. It is vital that the variation of different biomarkers can be captured at different timescales. It should be noted that the importance of features in different timescales varies among patients. For example, for the patient suffering from chronic disease, the feature extracted in the long term may be more representative for depicting the health. On the contrary, for the patient suffering from acute disease, the short-term feature describes the health risk more precisely. Second, we believe that the key factors that strongly indicate health risk are different among patients. It is critical that the model can utilize the features adaptively in learning the health representation and performing prediction for patients. Besides, medical experts need to understand how a certain decision is made by a deep learning model to a particular patient, so that the prediction results are trustworthy for developing individualized intervention and extracting medical knowledge. Moreover, it will also remind the physicians of the previously unknown correlation between the biomarker and death reasons. By jointly considering the above research issues in clinical practice, we propose the model AdaCare. First, how to capture the dynamic variations of biomarkers at different timescales. As is well known, The basic RNN module is difficult to achieve this. So let's think about this. The lovely dog can embed the earth in detail, but it is short-sighted. While the satellite can observe the earth in a big picture, but too much details are lost. We embed the patient from the aspect of dog and satellite at the same time. Our model adopts the dilated convolution with multi-scale receptive field to monitor the biomarker in long and short-term timescales simultaneously. It skips some of the time step to extend the receptive field and meanwhile keep the size of convolution filter. As mentioned above, how to improve the adaptability of AdaCare in terms of feature utilization for patients in diverse conditions. And furthermore, as we extract the sophisticated variation pattern of biomarker, the multi-scale dilated convolution module also introduces redundancy into the model. How to reduce this undesirable redundancy? We adopt the scale adaptive clinical feature recalibration module based on squeeze and excitation block. This block is trained to model the dependencies between features and selectively give more weights to the representative and predictive features but suppress the unimportant ones. For patients with different disease conditions, the key features in the corresponding timescale would be enhanced. And for more details about SC block, please check the paper of Hu in 2018. On one hand, if the model only depends on the historical characteristics, the alertness of its prediction will be compromised. And on the other hand, if the model depends on the latest record alone, it will be overly sensitive to abnormal values brought by the missing data and noise of EMR. Thus, the prediction may lack robustness. In our model, both of the historical characteristics extracted by multi-scale dilated convolutional module and the latest record are taken into consideration to build the visit embedding. The latest record is included via a recalibrated skip connection. For a particular patient, it can screen the most informative features. We conduct a decomposition prediction experiment on the mimic dataset and conduct the mortality prediction experiment on the ESRD dataset. Our model outperforms all baseline models across both datasets in all evaluation metrics, especially the area under precision recall curve, which is the most informative and the primary evaluation metric when dealing with a highly imbalanced dataset like the real-world EMR data. But now, we would like to spend more time to introduce the observations of extracted medical knowledge. In order to identify the reasonability of feature recalibration from an overall perspective, we calculate the average importance weights of biomarkers on different causes of death on ESRD validation sites. The weights are visualized on the figure. Albumin is strongly related to adverse outcomes of ESRD patients, especially for the PDAP. This is consistent with the medical research, which figures out that an abnormal value and decreasing trend of albumin usually indicates that the patient may suffer from inflammation and fluid overload. And besides, the chlorine is also a strong indicator, especially for the cachexia and infection. According to clinical experience, the chlorine level reflects the renal function of the patient to some extent. However, the relationship between the infection, cachexia, and chlorine has not been fully explored by existing medical research. This noteworthy medical finding has already raised the interest of medical experts. In order to intuitively show the implication and prediction process, we develop a visualization system. The horizontal axis denotes the visiting time. The vertical axis denotes the prediction result of health risk. As you can see, this patient had visited the hospital from 2007 to 2011. For the case patient, there's a distinct rising period of risk at 2011. This means that the model raises the alarm that the patient is suffering from a high health risk and would face the adverse outcome within 1 year. And unfortunately, the patient died half a year later. What happened? When putting the mouse on a single point, the key features of the patient at that time will be presented, which is determined by the weights generated by our model. The model predicts the mortality risk based on these features. Then we click the corresponding key features. The value and the important weight are unrolled in detail here. The model figures out that for this patient, the albumin, hemoglobin, urea are the key features. Obviously, the decreasing trend is a strong indicator of health risk. The results remind doctors that they should put an eye on these features and take some treatment to the patient to prevent or delay the adverse outcome. This is another patient. The model believes that for this patient, albumin and urea are still the most important features. But for this patient, the carbon dioxide combined power is considered as a key feature by the model. In this case, potassium is an important feature. We also use PCA, the principal component analysis, to reduce the dimensionality of ESRD patient representation on each time step and visualize them on a two-dimensional plane. Each patient has several visits. Each visit is denoted as a point. The line with several points represents the health status trajectory of a patient. The color of each point reflects the predicted mortality risk of a patient at that time. Red means high risk and green means low risk, or in other words, a relatively more stable status. The red point with the black circle age indicates that the patient died in 1 year. When putting the mouse on the sliding bar and move slowly, doctors can observe the trajectories and outcomes of patients in different ages. This will help the doctors to observe the similarity of different patients, predicting their future disease progression, and extract medical knowledge. Please feel free to scan the QR code to try the visualization prototype system. Thank you.